Good morning, everyone, and thanks so much for joining us today. Steve picked the song, Should I Stay or Should I Go? And you have all made the right decision. Steve and I were talking this morning about where we live, and I said, well, this week I feel like I live in this hotel. But it has been a really great week, and we have been talking about pushing boundaries, and one of the things I've been most struck with this week is that we're all leaders across the healthcare industry, and the one thing that is uniting us is this shared mission to make healthcare more efficient, more accessible, and ultimately more effective for everyone. But as we look at the landscape today, it's clear that some of the solutions we've implemented have been more like Band-Aids, quick fixes, easy solutions that are helping in the short term, but don't fully address some of the underlying causes of inefficiencies. So today's panel is about something different. It's about moving away from incremental improvements and instead really focusing on bold, systematic changes that are truly necessary to drive efficiency. This means thinking bigger, which we've been pushing the envelope on this week, and exploring how technology, regulatory reforms, and better data usage can drastically reduce waste and streamline healthcare administration, not just for now, but for the future. So today's panelists are going to help us rethink traditional models, provide some insights, and whether you're involved in policy, technology, or clinical practice, I encourage you to listen deeply, engage. We'll share some time for questions at the end. I think the conversation could lay the groundwork for some real meaningful change. We have a really diverse group here representing the health plan community, a physician, and a policymaker, so we'll have all perspectives. I want to start off by asking you all some basic definitions. You know, how do we define healthcare efficiency? And maybe a little bit more about yourselves too. What drives your passion to address these challenges? Steve? Sure.
So maybe we'll do the introduction first. You already got the long title, which is the longer you stick around in government, the longer your titles get. Steve Posnack from HHS, and many of you know us as our former office name is the Office of the National Coordinator for Health Information Technology. Equally long office name, so I'm not sure we did any better with the name change. But you know, our work has been, you know, for a long period of time focused on electronic health record adoption, interoperability, all of those good things that help to power some of the healthcare efficiencies that we talked through. And you know, from a healthcare efficiency standpoint, I like to just take a step back and look at, you know, what are the real people problems that we're trying to solve, the best care possible for someone, most, you know, effective and efficient, it's safe, it's informed by the best evidence possible. And so those are the types of things that we're looking at now in terms of how the data that is now digitized and accessible over the past 20 years of policy work and investment by all of you and your government friends, that we can make the most of it. So that's a bit of what gets us up every day and what's driving us.
Great. Meredith?
I'm Dr. Meredith Williams. I have the great privilege of leading the Office of Clinical Affairs at Oscar, which is a leading healthcare technology and insurance company. And I am also still a practicing ER physician. So I bridge both worlds. And when I think about efficiency, I think to some extent the answer you get depends on the seat you're in. So if I think about my plan colleagues, a lot of the efficiency conversation would be focused on much of what the conversation today and yesterday has been about, which is data interoperability, you know, getting basic information, right place, right person, right time. And I think those are all noble and important goals. Clinically, though, patients think about this in a slightly different way. They think about it in terms of accuracy and speed to diagnosis. So I see people coming in and you know, they're in distress. They have, you know, an uncertain presentation of some sort of pain, and they're like, what's going on? And so I think the health system in general is still got opportunity on that side because we see patients with delayed time to access, to delayed time to getting appointments. And then there's work also being done around trying to do diagnostic accuracy. So I think all of those are going to be part of this conversation of what does it mean to be efficient in the context that you're in.
Yeah, my name is Samesh Nigam. After a couple of decades as Chief Analytics and Data Officer at Independence Blue Cross, and Blue Cross Blue Shield of Louisiana, Johnson & Johnson before that. I now run a consulting company helping a lot of health tech companies essentially take on the same journey and work with many payers as well in the same vein. So in my view, picking up on what Steve said and what Meredith said, in the end, it's that vulnerable patient who's flying under the radar, chronic patient who has not gotten the care, doesn't have the right experience when they try to navigate the healthcare system. And if we keep that person in mind, really everything that we do, technology, AI, people, process, has to be focused on that person. And quite frankly, if we focus on that, then everything else flows automatically. Payers do well, providers do well, regulators are happy. So I think that's the focus. I think we'll talk a lot about data. Certainly, all the companies that I have been on AI journey for over a decade. We built large warehouses, first on-prem and now in the cloud, applied the first generation AI technologies, now Gen AI. But it's all with the same focus. Who is at the risk of getting hospitalized? If they're hospitalized, who's at a risk of getting admitted? Whose diabetes is getting worse? Which is a congestive heart failure patient who otherwise gets admitted twice, 2 or 3 times in a year, but can you avoid that somehow by providing resources at home? So those are the questions. If we keep, as I said, that patient-centric view, then efficiency flows. I mean, clearly we have to work a lot in the United States on reducing waste and overuse and so forth. That's a big challenge on its own right, but I still feel the patient-centric view gets us there.
Great, thank you. So, one of the central frameworks guiding healthcare transformation today is the triple aim. How many of you are familiar with the triple aim? All right, so we're still awake out there. Improving the patient experience, reducing costs, and really managing population health. And these goals are really ambitious, interconnected, and essential for the future of healthcare. But as we look at the industry in its current form, with rising costs, inefficiencies, and fragmented care delivery, we really have to think about, is healthcare really even sustainable as it is? And technology promises to play a key role in addressing these challenges. But I want to ask the panel, how do we truly unlock the potential of these innovations to make a real impact on the triple aim, thinking about interoperability, AI, customer-centric care? So I will start at the other end this time with Samesh.
Oh, yeah. So, Steve, your ex-colleague, Wendell Washington at ONC, he was the chief medical officer for the longest time in Louisiana. And he would tell me when we would talk about triple aim that, I can give you 2, but not all 3. Pick any 2. You can give you great experience and clinical outcomes, but at a high cost. Or you can literally do this game. Over time, we were able to prove him not wrong, but improve his perception of what can be done. And I really think analytics was that glue in the middle that played the role. So for example, Meredith will tell you that there could be very expensive diabetes management programs. And, started out in Europe, they went all over the place, cost thousands of dollars. But certainly you can't put them up as peanut butter across your entire diabetic population. Your cost is going to go out of whack. So that's where I think AI comes in, or analytics in general, AI in particular. If you can find out those fraction of people who are going to be impactable by your interventions. They may be expensive interventions. They could be home interventions. They could be intervention at the provider setting. They could be optimizing their drug regimen. It could really be any number of those. But if you're able to do really those targeted, instead of those blank calls that we used to make and to all of our diabetics, and nobody wanted to pick up the phone. So that allowed some really sophisticated and expensive interventions to be targeted. And when we did that, you started seeing actually the return on investment. So the third part of the triple aim, right? But if you didn't do that, if you didn't target well, then of course those programs would fail. So I do feel that analytics has a strong role, and if you don't have highly predictive models driven by now really by AI, it's really hard to do. You can do some basic stuff, but you really can't do some of the more sophisticated strategies. So.
I'll go. I think that's right. And Oscar in particular is focused quite a bit on this concept of sort of almost personalization. Where do you start to say we've had the right recommendations in terms of general screenings, but we are still challenged to ensure that those are delivered to patients who are higher risk in a higher frequency or a more, I would say, like precise way. If I think about it from a clinical standpoint, patients will come in with a presentation. So you think about like chest pain, it's undifferentiated. And some are higher risk, some are not. And so our protocols and pathways today are not particularly personalized or differentiated. They're good because they're broad screenings, but they do mean that people are having essentially workup they didn't need because ultimately it turned out that someone's chest pain was heartburn, whereas someone else is having a heart attack. And those are very different things, but we don't really know how to differentiate those. So I think analytics will play a huge role, predictive modeling as well. And then we have this rise of diagnostic capabilities coming out with genomic medicine in particular, and we're starting to see a lot more coming out that can, I think, help with that precision medicine and what that means in the intersection with population health.
I've heard that healthcare is complicated. And I think we all have lived experience that is true. Interesting for us, as we approach these challenges, there's always technology and policy and payment related intersections all over. And so just to give you two quick examples, new technology allows for clinical messaging. Great. We're going to make it easier to communicate with the doctor in their office. That's then created inbox overload, and providers now charging for that time spent on responding to clinical messages. So there's lots of ripples that start to occur from a new technology intervention. And then you look and say, well, what kind of policies or payment models are in place? Are they the right fit or aligned with the new intervention that we chose? And you can kind of spin the wheel another way and say, all right, we're going to introduce a new quality program, and that's going to create a whole new set of responsibilities. The other is around electronic prescribing. And I think we've seen trends over time that we just keep getting more and more prescriptions issued. I don't know if that's a good or bad thing. I know that the systems are getting smarter, and they're able to look at clinical evidence and provide clinical interventions at the point of care that maybe a doctor would have missed before. And so maybe someone is getting a medication that they really should have been on earlier, or could have needed and would have been a gap. And that's resulting in an extra prescription. But we do see prescriptions rising. And you can split that again by whether it's opioids and that type of related drug classes, or if it's just other kind of chronic condition management. But all of those require looks across the board at all these different dimensions. What policy levers we have in place, the payment models, and whether or not they're incenting or supportive of continued fee-for-service related behavior, or if there are alternative models that need to be approached.
If I may just add one comment around experience, that's piece we haven't talked about. Years ago, we built a model in both the companies that I was there, where we just said, there's a lot of conversation that's happening with care management, with call center, where people are calling in, right? You just get more than 1 million calls. Could we not take a look at that text and figure out who's going to complain? And that was very important for Medicare Advantage, because of course one of the stars is for customer experience. So the whole idea was that could you predict who's going to complain before they complain, right? So a lot of people used to laugh and say, make one for my spouse. But, but as it turns out, it can easily be done. I mean, when you have these words coming out, people get agitated, the sentiment analysis, certain upset, my bill was not paid, or my prescription was declined, whatever it is. You can combine all that and create a score, a complaint score. And what we found, and those are some of the most stable models that have been running both at IBC and Blue Cross Blue Shield of Louisiana, and it's been published, so you can put my name and Google it, that when we were able to predict the complaint and able to make that outbound call, the complaint rate went down by 2/3. That's a dramatic improvement. Both companies actually became 4.5-star plans. I think they may even hit 5 now. But that 1 star for customer experience went through dramatic. So here's an example of not claims data, not clinical data, but really just the way we talk to each other, and we know somebody's getting upset, and now we're using technology to find that. And we would find all kinds of interesting things why they were upset. It had to do with operation. We were not covering something which for a few cents more we could have covered that product, and the complaint rate would go down. So those are the kind of things there. Technology, I think, can play a role. Yeah.
And I'd like to also just build on the comment around the inbox. I think is a great example, because we think about efficiency from a patient standpoint. That's wildly efficient. From a physician standpoint, this is starting to be not. Right? So all of a sudden in my clinical workflow, I have everything I need to do. I'm still measured on a patient, basically patient per hour rate, and then you have all of these inboxes. And so some of what's become, yes, the answer has to be analytically based, but that requires large and robust data sets, which we are generating. We're generating huge amounts of data, right? If you think about the home devices, monitoring people with CHF at home, or a variety of different digital therapeutics, the volume of data is now becoming part of the challenge. And because the only solution we've had up until now has been humans. So we've hired fleets of care managers to try to sift through this data, or analysts. And I really think that's where this AI promise comes in, because we've started to have a volume and scale problem that is starting to outstretch the capacity of the individual to do, and making it so it's harder almost to focus on what it is you're trying to do. So I think there's a place to be looking at the clinician experience in parallel with the individual patient experience, and saying, how does this whole system work? Because that's some of the cost. Is just, it takes more people now. You hear this from physicians, to run an office, to do a number of basic functions than it used to, because of the data that they have to manage and generate.
If I can
go ahead.
give one more just real people example, right, with myself is, and this gets to the efficiency point. So needed a lab test to determine if I was going to go on a particular medication. The doc ordered lab, went to get the lab, thanks me. I got my lab results electronically as soon as they were ready. And then we set up a 15-minute video call, fit within my life, plan. And he jumped on, we talked about the results, and then he prescribed the med. And amazing. And so for that, and for other individuals that have access to telehealth services, and that's a technology issue, and it's not widely available to everybody, but it saved me driving, it saved me time off from work, and those are things that are real factors in people's lives. And so I think it's all that technology that we're putting in place that makes a difference.
Yeah, absolutely. And this really gets to the next part of our question, which is, in healthcare, triple aim, let's make it a little more complex. Let's do the quadruple aim, right? And now we're also thinking about the health and well-being of our staff and our healthcare workers. And this is all amidst a, growing, aging population. So I think my next question is really, where do you see opportunities to address some of these challenges? And you've touched on it a little bit, but more so some of the burdens that it's creating. What are the opportunities?
I can go first.
Yeah, go ahead.
So I think some of it is really the embrace of the team concept model. So Sarah talked about this in her panel around, it isn't really a single provider caring for an individual at this point. It's really a team. It's a team of physicians, nurses, pharmacists, care workers, social workers, also administrators. There's a lot of administrative work that's going on behind the scenes, and those folks still feel very purpose-driven. And so I think this idea of, not just, right care, right place, but also right skill level. Where do you really need to have the physician level trained individual, and where do we not really need it? And I think there's been a recognition that there's actually more space for that team to provide a lot of the core and basic services. So I think that helps. I think looking at also, though, the provider experience as a goal also really helps. It's not been at the core, which I want to say is, I think coming from a good place, which is putting the patient first, which is what we're trained to do. But we are seeing very high levels of burnout and fatigue. And I think taking care of those caretakers also has to be starting to be some of the goal. And what does that look like in terms of reducing their administrative burden, doing things that are more efficient for them. Also just simple conversations around time off. There's a lot of structures in the way physicians are employed where you don't necessarily get parental leave or things of those natures, I think are part of the larger societal conversation around we take care of our workforce, which is taking care of us.
Yeah, I read somewhere that even if United States were to hire every nurse that ever graduated anywhere in the world, it still wouldn't be enough. I don't know whether that meme is still true or not, but it did say that not only where we are heading with aging population, certainly there'll be burden on healthcare providers. I do feel that this is another area where I think technology can play. I mean, so far it has worked the other way, right? I mean, you ask an average physician about EMRs and pop-ups and things that come in, it's really not helping. And I still remember one of our CMOs, I went to them with a list of high-risk patients. Hey, we've got this great algorithm. Take a look at all these people who need help. And he looked at me and said, well, so what? What will I do, right? So they wanted not just predictive analytics, but what we call prescriptive analytics, where really the technology is serving as an assistant. It is actually assimilating huge amounts of information which a person can't possibly do. If they were trying to do, they will just overwhelm themselves. But as an intelligent agent, be able to give some recommendations. And then physician or whoever is the care provider, nurse, should be able to say, yeah, this makes sense. I'll go with that. So I think that level of technology simply was not available, but now it is. So I do feel the next few years we'll see a lot of opportunity.
And if I can just piggyback on that, the most efficient thing I ever had happen to me as a practicing physician was a scribe. That was it. It went from about a patient an hour to 3 patients per hour. It was paying a human to literally follow me around and do my notes for me. The note quality went up. They were more consistent. Templates were always filled in, and improved coding and diagnostic coding accuracy. It didn't actually change what I did in terms of actually practicing, but it was wildly efficient. And so that's a space where I think technology is also starting to play out in terms of looking at these sort of ambient AI-based scribes. Oscar is really excited about some of this in our primary care group. And we see this also in our member feedback of where we think there's going to be willingness for adoption. You see in the panels where you interview members, that's like, yes, we're absolutely happy to have it help the physician and be an assistant. So I think there's going to be some space there. Sorry.
Yeah, that's fine. Great. Aaron told us we could take control of the panel. So in a few weeks, we're getting close to that time of the year when you sit around the table and your family member turns to you at Thanksgiving and asks you how work is going and what you do. And then you attempt to explain to them what it is that you do. And they probably walk away more confused. So I look at this a little bit from my mom, who's in her 70s, and I bring up family because they give you the most piercing advice and or input in your work. And so her quote is, "I don't want to be portaled." And I was like, oh, stab me in the front, from the in the chest. And so I look at that and I'm like, she's also the same person that still pays with checks and still insists that I print her out a boarding pass, despite the fact that we've gone through the mobile boarding pass options numerous times, and wants to see her providers. And so I think we just have to recognize, like, as the population gets older, there are both preferences and digital literacy related dynamics that we have to keep in mind as well. And just there are going to be some aspects or individuals in our population that have found what they like and they don't want to change, and we have to make sure that the system stays with them in that regard and meets them where they are, and then equally shows them other opportunities and gets them involved. So, like, once we did the mobile boarding pass thing once, I was like, oh, you made it. And then she used an Uber, and I was like, oh my God, you're in the 21st century. And so, it's like giving those types of experiences where sometimes it's just scary. It's confusing, and they don't know how to use all the technology that some of us have grown more accustomed to and depend on daily. So those are a lot of the factors that we rush ahead and we build a lot of things, but we're not sure that everyone's coming, and they don't necessarily have a need to come to get that type of stuff. All of us have access to our electronic health information. How many of us are accessing it on a daily basis? You need it when you need it, and that's part of our mission, is to make sure that when you need it, you can get it easy and efficiently. But those are some of the challenges with the aging population. As we keep pumping out more apps and more AI, it's just going to leave them behind.
Yeah. I'm picturing Steve at his Thanksgiving dinner, taking notes for his presentation.
I bring the whiteboard out. I'm like, get ready, everybody.
I'm going a little off script here, but one of the things I was thinking about the other day was, I was at my physician's office, and new physician, have you had these lab test results? Oh yeah, and here's what they typically are. They're like, well, could you get your physician to send it? And I'm like, well, I have it right here. And they wouldn't look at it, would not look at my patient portal information because it wasn't from their practice. And how do we get better about sharing that information, more comfortable with it? Steve, I know that's something your team's been thinking about a lot.
Yeah, I mean, we hear that story all the time, where the doc can't access it, but then you pull it up or on your phone or portal, whatever, and some of them do look at it and they're thankful that you're able to get it for them, as opposed to faxing it. We see this with imaging still today. It's another, pebble in our shoe, larger than that really, is that all of us are still getting DVDs. The only reason why our kids know that DVDs exist is because of imaging, and at this point. And so, I think it is kind of both a cultural shift that we're seeing as well. My wife had a similar example where she went to a new doc. They happened to be, I think, on Epic, and were able to get information in, and they had results from her from 10 years ago. And she was like, how do you have that? But they didn't have results from 2 years ago, which was really why she was there, to have follow-up. And so first I was like, you're welcome, isn't that amazing? And then she told me that they didn't have the other results that she needed. And I was like, all right, I'm going back to work. So, it's that type of dynamic where there's still gaps in terms of, where we need to fill things in. But your experiences, the mileage varies.
Yeah. So, with all of these advancing technologies, how should we really be thinking about quality in the future? And I think this is another quote from Steve that he said in our prep session: one organization's inefficiency or waste is another organization's profit. So how do we kind of move beyond this in healthcare, and how should we be thinking about quality and cost as we look at these big innovations?
Yeah, I mean, I think I'd definitely like to hear Meredith's view on this from clinical quality standpoint. I mean, I do think that we are just swimming in quality measures. I mean, I think one time I asked my team to just make a list of all, HEDIS is one, but there are many, many, many ways you can. Blue Cross measures quality in one manner. We call providers Blue Distinction Centers. Local Blues do the same thing. Payers do the same thing. There are a variety of clinical societies that measure quality in different manner. We really have an overload of quality measures, and it'll be useful to try to have a set that we can all agree. I mean, really, quality of diabetes management should be fairly standard by now. It shouldn't be so many different things. So unfortunately, that is a problem. And what happens when you have way too many measures is that you start focusing on the wrong ones, and sometimes for the wrong reasons, right? Certain measure is just easier for us to get to. I see that all the time when we're trying to work on the Medicare space. I know we need to get X score, and that one we can do, this one we can't do. So maybe clinically meaningful more or not, but you end up driving confusing behavior. So I do feel that it requires maybe through government initiatives some focus on figuring out, at least for common diseases, diabetes, hypertension, other related cardiometabolic diseases. May not have to go into each type of cancer yet, and people are trying there too. But at least for the major chronic diseases, there should be some alignment, which I haven't yet seen. So.
Yeah, I would just second that. It's not just variable by payer, so you have different measures for Medicare Original, different measures for Medicare Advantage, then you have ACA, and that's different there, and then commercial is its own thing, and then you've got Medicaid, and then sometimes it's not even the same cut points across those measures. So you can say, let's say we're doing a diabetes program, and one program has your measure of success as a cutoff at 6, and the other one has it at 11, right? And it's just, it's variance without purpose, and I think there is absolute room for standardization, sort of similarly to how we're moving towards FHIR standards for API. These sort of quality standards for the actual structure of them, I think will help. I also think it's a space where, the payer metric world is still different from like the clinical metric world and what you're trained on clinically. It doesn't actually bring any of those measures in ever, by the way. Then you go through residency, they never talk about, here's your STARS measure report or any of this. And so I think, how do we start to make those two worlds, frankly, a little more cross-visible to each other? And then the patients they still say high quality care is somebody listening and doing the right thing, but there's still a non-quantitative component to that, which we try to capture with NPS, or we try to capture with other measures, or these sort of feedbacks, which is okay. But I think there's got to also, though, be a space to start to measure not just the individual, but also the system. And so some of what I've observed in my own practice is really what I can do is heavily influenced by the system I'm working in. If I'm working in a rural environment where I am literally the only doc along with the surgeon and there's nothing available, I am practicing a different type of medicine than if I'm working where I am now, which is Metro and I love, which is resource rich and there's residents for everything and I can just do a lot more. And so I think we have to start to recognize that physicians have largely transitioned to an employed versus an independent practitioner model. And what does it mean for those metrics to start to track to that? You know, we're process people, right? The system, the team, how do we look at that as much as the individual? Because it's tricky. It's hard to influence some of these things by yourself.
I have to say this slowly so I don't get the saying that I'm going to use now wrong. There's standardizing clinical practice, and then there's standardizing how clinicians practice. And too often I think we go to the latter and how it feels, just based on, like, take a step back and how that feels for a lot of these quality programs. And I know from past experience, having been at this for a minute, like, when Meaningful Use Stage 1 came out, for all of you that are, you know, veterans of that, it felt, based on feedback, more like the latter. We were standardizing how clinicians practiced versus clinical practice. And that is a friction, I think, you know, as I you know, try to take a step back and look at some of the work that we do, where the diabetes management is a great example. Like, there's real standardized clinical practices that should be consistent, and quality measures should be consistent, and the thresholds across, you know, the payers and CMS and everything, we should get to those places of consistency. But how much does that dictate how one clinician practices versus another, as long as they're consistent with those clinical practices? And that's something I don't think that we've quite, you know, hit the nail on the head yet, because we do get that feedback. That fits in with all of the clinician burden reduction activities that the department's involved in, but it's a dynamic that I think continues.
I want to talk a little bit about policy and regulatory opportunities as well, and I think, I'm sure, Steve, you feel this pretty regularly, the tension between driving the adoption of digital tools and enhancing efficiency, but not stifling innovation, and how that process and timeline works. How can we create a system that rewards genuine improvements in patient outcomes?
Oof, it's tough. I mean, you know, all of you probably operate in environments where they're like, tell us when it's required and we'll do it. You know, that is a model from a regulatory perspective that we're in with a lot of the programs that exist, right? There's a cadence and there are iterations and it changes. We try to introduce, in some cases, new approaches like the FHIR APIs, which can be more generalized and used across a variety of different purposes. In other cases, there's a lot of work, I would say, from my office's standpoint, and I know for our colleagues across HHS, to try to do more outside the regulatory space and be collaborative with groups like NCQA and others to you know, get work done that can move a lot faster than the government regulatory pace. Yeah. So it's a combination of both.
Yeah, absolutely. I think from our perspective, there's a lot that holds promise, but there's a lot that needs to be learned and figured out. And I don't know about you all, I'm going to tell my team, we're going to learn by doing. We're going to learn by doing. And so how do we start to really, I think, embrace some of the best practice that I think the scientific community has come up with, which is this sort of trial, test, learn model. Because there's going to be, you know, so small scale opportunities, then that's going to be medium sized, and how do we still allow for that innovation while still trying to make sure it moves quickly, but we don't sort of regulate it before it even does anything at all. I think those are some of the places where we're excited to be working with, you know, regulators and others to say, Oscar's committed in particular to transparency and publishing and saying, here's what we're doing and what does that look like? Because this does need to be a public conversation. And I think the more that we have that transparency in how things are going and the data integrity to back it up, I think the more we build trust. And that's something that I think, again, the scientific community has a really long history of doing very, very well, and then working with regulators to get products released and new therapeutic modalities. And how do we start to do things for technology in a similar way that allows for us to still capitalize on some of the dynamism of this incredible place, but also recognizing that we're dealing with healthcare and we have to be careful there in ways that are unique.
Yeah, my view is that there's plenty of opportunity for innovation. At least I haven't found in my career any of the regulations to be, you know, you obviously have to follow HIPAA, you have to be respectful of all the regulations that are around, but can you not use data then to figure out what the innovative approaches are? No, you can't. That's well within your wheelhouse. So I try to give people examples that often people lack the capability to have all the data together, have the analytic expertise, have all the pieces that are needed, outcomes evaluation, to be able to figure out. I give an example to many people that well before I arrived in Louisiana, there were a few nurses who decided at BCS that they will make copay free for a small group of 1,000 people who are good citizens, basically. They are engaged with their care management and all that, but they're poor, we'll make their copay. But nobody ever studied it. This program just went on. And when I came, we said, well, let's evaluate these programs. We have 7-year history on this. Let's see what's going on. And that, the signal lit up like a Christmas tree. You could see that whatever money we paid for copay relief was 3x to 4x offset by fewer admissions, fewer specialist visits, better outcomes. So I went to our actuaries and said, we need to scale it up. And so with great difficulty, they went up to 5,000, and we tried that, and in fact, it worked, and went to 20,000. Now 100,000, almost 10% of Louisiana's commercial population basically gets a big zero. I mean, they don't pay any dollars, and that program is being replicated nationally. In fact, the outcomes continue to show that 3x improvement in cost and, of course, better outcomes. So I do feel that this all could be done within the limits of all the regulations we have. So I think sometimes we try to cop out and say the regulations are trying to stifle innovation. I don't think that's the case. I think we really need to drive towards it. Of course, they can make it easier, interoperability, transparency.
I'm going to take you with you on every panel.
Yeah, but it hasn't proven to be an impediment, I don't think. Yeah.
Steve, could you talk a little bit about HHS just made some big changes around the Office of the National Coordinator and bringing together some different areas. What's the vision for that? And with focuses on things like AI, how do you manage the pace of change and innovation from your lens?
Yeah, really quickly, Thanksgiving's going to be interesting this year. So in July, we got reorganized a bit, as the new title suggests. And so there's ONC Classic, which you know and love, plus a bunch of department-wide responsibilities now. So that includes the kind of refresh of the HHS Chief Technology Officer, the HHS Chief Data Officer. So for those of you that have ever gone to like healthdata.gov, that team manages all of the open data activities for the department at large. And then the newly created position of an HHS Chief AI Officer as well. And so all three of those now are part of our Assistant Secretary for Technology Policy Office, as well as all of the ONC functions you're well familiar. And so that means that we're going to be taking on a lot more department-wide activities and giving guidance to our colleagues and working with them hand in hand in innovation activities and data activities and AI activities. On the AI side, just to be clear, we didn't get any additional new regulatory authority. This is really more kind of corporate management, so to speak, of HHS and providing a single point of contact, authoritative leadership and guidance for the rest of the department. So there's work that we have to do for compliance-related responsibilities, which always exist in government. And then we'll be looking to help see where we can help other agencies within HHS modernize their mission activities through the use of AI. There are a lot of groups playing around. We have agencies that are exploring chatbots and other things like that, which is, I would say, like a baby step toward artificial intelligence use. Wouldn't it be great if you could go to, I'll pick on CMS for a second. You go to CMS and they have a regulatory chatbot and you can ask it a question, right? And that's a future that we're looking at as hypothetical. We have to get to a point where the answer that the chatbot would give would be the answer that our human analysts would give, and that's going to be a pretty wide gap to close. But there are other places where we can look and be more efficient if you want to find, different guidance, or you want to learn about certain Medicaid programs, and you can kind of see a world where you can plug all that information in and have it be more of a conversational kind of chat-related moment. We know that on the program integrity side, because you mentioned fraud and abuse earlier, that's been running algorithms to detect fraud and abuse for years. Now they have more advanced tools that they're looking at to figure out, can we look and see new patterns? So there's a lot of innovation internally happening within the department, and we're helping with that too.
Great. I do want to leave some time for questions today. So before we open it up for questions, one last question for you all. What's like 1 to 2 kind of no regret moves that you think we should be making now, whether technology or policy focus, that can really help us kind of move beyond the Band-Aids and move into this digital age where we're truly transforming the way we deliver healthcare?
Yeah, if I may start. I mean, I certainly think data integration is a no-regret move. I mean, data is the fuel for analytics, AI, Gen AI, really anything. And unless you have platforms that allow you to bring in this data in a standardized format, be able to apply tools, whether in the cloud or elsewhere, on-prem as they used to be, but be able to do that analysis and have that capability. These turn out to be, at least in insurance company context, some of the most expensive capital investments made, at least under the places where I was. So they do require CEO level approvals and their sponsorship. But I do think that that's something that if we are not on that, we'll be left behind. So, yeah.
I think some of the basics are just sort of really the core operations behind the scenes administration stuff within healthcare. I know there's a lot of chatter around sort of diagnostics or sort of helping patients understand their care, which is great, but there is a lot of paperwork that happens behind the scenes. Some of the very basics in terms of just like claims adjudication, making eligibility and benefit checks. My team in particular, in our world, I oversee all the clinical policy for determination of prior authorizations, and so there's a lot of work that's put into those policies, but then they have to be implemented manually, and sort of where do we start to say, hey, it doesn't change the answer, but it gets it to you in real time, and so you know what it is, and simple things like not just saying, okay, we're going to do an eligibility check, but we can actually do it with the code, so you can actually know what your copay would be for this service at the point. Those are the places where I really think that you just see, I would say, wide agreement that is a no-regret move. And that's where I think you're going to see real action, is when there is wide agreement. So those will be some of the places I'll be excited to help implement.
Yeah, I will just jump in because those of you that read the CAQH index report every year, there are $18.9 billion opportunity in cost savings if we just automate those remaining revenue cycle transactions. Yeah. If all eligibility inquiries were done electronically, we would save an enormous amount of money still. So there's still a lot of opportunity on the table. And with workforce challenges, it seems like a no-brainer.
All right, I guess I won't get paid unless I say this, right? Focus on standardization and data quality. I think all the examples that we brought up are also met with a corresponding version of that example where the provider looked at the data and they're like, this is a bunch of crap. Mm-hmm. And so there's still room for improvement in what we're sending to each other and what we're getting back. And then what's being used to measure quality and all along those lines. So the more that we can do work in the trenches on data quality and improving the quality of the data that we're shipping around will be low regret.
Yeah, absolutely. All right, questions for our panel?
Good morning. I just wanted to thank all of you for what was honestly really refreshing to hear. A lot of what I was hearing was kind of about how technology can be used to stratify risk, how there's like a need for looking at the whole system. I really heard everything but misaligned incentives. So a question I have for you is, how can we use all of the stuff that was discussed, looking at a system-wide view, a patient-centric view, and how payment is used to kind of triage patients to the level of care they need? Because not every patient needs a physician, but some patients need a bit more than a care manager. How can we connect patients to people so it remains accessible? Maybe send them to pharmacists, nurses, virtual professionals who are in telehealth. And what are plans doing about that? And is there anything from a regulatory point of view that's being done about that?
Yeah, I mean, I would just say, thanks for bringing that up. And indeed, we didn't talk about misaligned incentives. That's another one of those hairy animals that can take a whole day if we all start talking. But value-based programs, and at this point, value-based contracts that tend to be the mainstay for most of our plans, I'm sure at Oscar as well in the Blue system too, they are trying to cross that gap, right? You're trying to pay at least a big chunk of incentive on overall care of the member, patient, whatever you call it, versus fee for service. And within that construct, you can then embed different quality measures or other operational measures of efficiency that you incentivize. Have we come up with an ideal construct? No, but certainly more and more of the fee is at risk for providers for managing the patient's right versus just adding up services. So we still have a long way to go, quite frankly, in my view. I'd love to hear from others.
In addition to the value-based care answer, also the quality conversation plays out here. So the quality is measured on the provider side. It's also measured on the plan side. So if you look at like the HEDIS measures in particular as a component of STARS, they've started to switch over time much more clinically focused. You see an evolution in that metric set on the payer side. So you start to see an interesting sort of swapping going on where the providers are starting to have some component of financial risk management, which used to be exclusively the payer space, and then the payers are starting to have some component of sort of clinical quality outcomes, which exclusively used to be the provider space. So the two worlds are still sort of moving towards each other. I still think there's a lot to go, and I think incentives matter. But we're also still seeing a lot of regulation, particularly in the ACA market, we're regulated at a state and federal level. So we see a lot of dynamism in the states saying you have to cover certain essential health benefits or these types of things. And so I think that's all to the good because we're all trying to figure this out and sort of move in the right direction.
So yes, I was looking at the actual title, Beyond Band-Aids, and growing up, Band-Aids never matched my skin. So I'm wondering what's happening in politics to help the disparity in healthcare.
So there's a lot going on, especially within this administration that we've been working on. We've approached our work from a health equity by design type of from the beginning, building it in. And then looking across different areas where we can make investments in underrepresented participation, underserved areas. We've financed now for the past 4 years public health and informatics and technology workforce development that went to minority serving institutions as well, because we don't have enough people involved that have different backgrounds in the workforce. And so it's partly to make sure that we have more diversity within our workforce, more perspectives, more backgrounds, and equally that for the programs that we're running, and this gets to the AI and all the other aspects of like there's bias and discrimination and these things are systemic, and they're also getting built into the policies and processes. And so we have to find new ways from a policy-making perspective to understand and better approach some of the challenges that have been harder to see. Our colleagues at the Office of Civil Rights also issued a rule recently. It's called Section 1557 under the ACA, which has to do with non-discrimination related policies as well. And so it's technology related, which is why I bring it up, because it's, I think for everyone's, I'm gonna say regulatory understanding on the spectrum of things, but the department has many different authorities in many different areas, and many of you know OCR for HIPAA, but they're really the Office of Civil Rights. And so they do both. And now on the civil rights side, you're seeing a lot more involvement based on how new technologies are being used and applied in the healthcare context.
I think it's a great question. I'm glad you asked it. So first of all, I do think workforce is a huge just first step. Like, how do you have people on your team from a variety of different backgrounds, a variety of different experiences? I think is critical to having those voices at the table. And that's a space I'm very proud of Oscar for being, I think, a leader in particular in an industry that hasn't had a lot of diversity. The payer industry has not. And so I think that's the first step. But I also think there's some really interesting activity going on in terms of the conversation around benefit and plan design around communities. And what does that look like? So that's a conversation that we are actively having with our regulators around building benefit packages to meet community needs. And what does that look like? It started with conditions. And so we have plans that are diabetes focused. We have plans that are the Breathe Easy plans. We're starting to say, what does it mean to build for a population? And if you look at a population, not just as a population by diagnosis, but you look at a population similar to, when I practice in Cleveland, and I work on the east side. I serve a largely underserved minority population that has very specific dynamics to it that are different than the population I served on the north side of Chicago. And so I think that conversation is absolutely going in the right direction, and I'm very excited about it. I think it's only going to go further. So thank you for asking.
Yeah. A couple of things I would add to that. Until a few years ago, we didn't even know what the ethnic mix was in plans. So if you wanted to divide our outcomes by ethnicity, race, or any other measure, social determinant measure, we were unable to do that, right? So one of the things that happened in the last 4 or 5 years is that we have accumulated that data. And so now indeed, we can see how are diabetes measures amongst African Americans, among Hispanics, amongst Asian population, or any other. So for the first time, plans are actually seeing these differences. So obviously the discovery is the first part. A little bit aside on AI and biases. So one of the last things I looked at before leaving the plan world to be on my own was to take a look at, is AI really biased in our case? You know, we were running risk of hospitalization, for example, which was our flagship model, predictive model. Everybody got a score. And we said, well, let's take a look at, now that we can slice the data by ethnicity, let's see what it is telling us. In fact, we found that there was a counterforce. It was not biased. In fact, it was finding people who were flying under the radar. So in some ways, AI was able to pick up bits and pieces of information that were there, but they were not connected. So now we were able to find somebody who really had not sought health and had clearly other struggles of poverty and others, and we were able to find them. Because without that, often programs were enrolled through physician referrals. And if physician themselves hasn't seen them, then how will you pick them up? But then a stray phone call, something that a person said, you know, my drug was not filled, or perhaps a dated clinical result which already was off chart, but was not then tracked further. All of that combined to give a score, oh, you know, Mrs. Jones needs help. And we were able to find that. So I think I'm actually hopeful that while we will be looking at AI and it's, you know, obviously everybody talks about AI and bias, there may be a counterforce as well, which is to find people who are flying under the radar. Yeah.
So first, thank you so much for sharing. In January, I had the opportunity, I was invited to the First Minister's meeting in Paris, where the title was The Future of People-Centered Health Innovation. And it was the exact same themes that you're discussing. And you can imagine a panel just like this with the First Ministers talking about innovation and transformation and sustainability. And the US Secretary said, I agree with everything here, but in America we have something called Wall Street. We've got shareholders. And he said it with a point of pride. So he said, how do we think through these things from the lens of incentives and thinking through the incentives to create this transformation for patients using technology, using AI. So I'm curious in terms of your point of view around acceleration from the vantage point of those types of incentives, which unfortunately or fortunately also have an impact for patients.
I can go.
Go ahead.
So,
yeah.
you know, it's interesting if you think about shareholders and healthcare, that can definitely give some heartburn in various communities. But I think the other way to think about it is if you look at the insurance in America, the trend is towards federal products or state-based products, right, of some kind. Medicaid is growing, Medicare Advantage is growing, ACA is growing. We're excited about ICHRA for small group and that growing. And so over time, you know, we've really seen a shift in our payer mix towards publicly financed to some extent, via its direct or via subsidy. And so we're at the point where, you know, the subsidies are a huge way that, you know, as a bipartisan issue, getting folks access to, for us, the exchange. In that regard, we are all shareholders because those are tax dollars. And so we all have an incentive to ensure that those funds which come out of people's paychecks are used efficiently. I tell this to my team quite a bit. You know, we work in the space of utilization management, which comes under a lot of review, and rightly so. But I view it very much as a stewardship role because we are trying, as an organization, we get premium dollars from someone's, you know, out-of-pocket post-tax paycheck. those are working parents, right? This is the ACA community, right? These are not retirees. These are going to be individuals. These are on their own. They don't have the option for insurance from their employer for whatever reason. They're not eligible for Medicaid for whatever reason. And so they're paying for this out of pocket. And so how do we steward those dollars? Because I've personally been, in a position in my life where I know what it means to really value a dollar. And then nevertheless say, but we want people to get care. And so I think that mentality of stewardship of essentially public funds is important and will be part of the conversation.
Yeah, one thing I would add is that Wall Street is not necessarily a bad thing. I mean, in the United States, certainly there's a huge amount of healthcare innovation and a whole ecosystem of startups that come up with amazing technology, continues all the way till AI. I try to remind people, at least at my age, you probably all remember there was an HIV or AIDS quilt, you could recall, covered the entire Washington Mall, that everybody brought a little patch of whoever had lost life. Today, we think of HIV as a treatable disease. There's so many other, we certainly did huge headway during COVID era, and healthcare informatics and technology continues to add innovation. So I would actually say that yes, there's a profit motive, and it should be kept in some sort of regulatory framework so that it's not, and we do, and certainly that we now, CMS can negotiate on drug prices, so that's a good thing. So there are many things that are going on, but I do feel that this innovation actually keeps us ahead of the world in terms of coming up with new solutions, and many of the solutions that are developed in the United States then get spread all across, and as is the other way flow. So I think we should encourage innovation, and unfortunately, profit motive seems to be the one that actually gets there fastest for startups, right?
All right, well, I think we're at time, so thank you all very much for joining us today. It was a wonderful conversation.